Okay, we are live. Welcome, everyone, to Level Headed Mind. My name is Giselle. I'm a psychiatric nurse practitioner, and I am answering your mental health questions today. The way that this goes is we will go. It is 11 a.m. Eastern here. I'm in Florida, so 11 a.m. Eastern Standard Time. So we'll go for 2 hours till 1 p.m. Eastern Standard Time. And I will answer your questions as far as in the order with member. So those who are members will get priority answers, super chats, and then, of course, the live chat in the order in which we get them. Okay. Our next live is going to be August I believe it's the 17th. Yeah. August the 17th will be the next live. As long as Raul is available for me that day. He's the one who helps monitor the comments and things like that. So that is what we'll be planning. So those who are watching the replay, if you want to come and join us live, it'll be same time, 11 a.m. Eastern Standard Time till 1 p.m. All right, so let's get into it. I believe we have questions already coming to us in the comments section. And we've got our channel member, Jim, here. Wonderful. Welcome, Jim. So Jim is asking, he says, good morning to you. What are your thoughts on genetic versus name brand medications? Do patients see more success with name brand versus generic? Well, actually, for most people, the answer here is no. There is not a big difference between name brand and generic on the way that the medication works. However, there are some people who are a little sensitive to the components of generic medications, the way they're compounded, and maybe they're sensitive to some of the fillers in the medication that could potentially cause some reactions, or they may feel that it makes the medication less effective for them because they're having some kind of reaction to it that may seem or look like anxiety for some people. So, but that is not the majority. So for most people, yes. Generics can work just as effective as the brand names. They're using the same chemicals. It's just they may be adding different types of additives, colorings, dyes, and things of that nature, where some people can be sensitive to them. Thank you for being here, Jim. All right, Nerd Bama's here as well. Wonderful. Good to see you. So as you know, I've been on Effexor and Boost Bar as well. Yeah, I finally took the gene test and it said that Effexor didn't metabolize as well based off my DNA. It wasn't in the red, it was in the yellow. That's very interesting. The thing with the yellow on the gene site test or even the GenoMind test is that you just have to be cautious with it. So either you're slowly metabolizing it, so you just have to be careful and stay at lower doses, or maybe you're metabolizing it a little too fast, so maybe you need a little bit higher doses to get the same effect. But if it's in the red, then that would mean that it wouldn't be wise at all to use that medication. Being in the yellow just means that we have to be cautious, and it just depends on if your serum levels are too high or too low, depending on how you would be cautious in using Effexor. So make sure you read the fine print there. And if you've had it done with a provider that is familiar with understanding how to read these results, then they can help you. Because if Effexor is working for you, there's really no need to switch to something else unless it's not working well for you. Then you may want to look to switching to something in the green category and do like a crossover. And you can tell your provider, if they're unfamiliar or how to cross over medications, to look at switchrx.com. It's good seeing you. All right, Ganesh T, good seeing you too. You're becoming a regular. All right, ma'am, can I take atomoxetine lifelong, or after using for prolonged, will I develop tolerance or desensitization like methylphenidate? Well, you don't develop tolerance. Let's see. I already take atomoxetine. Can I add? Okay, let's answer the first question and then we'll answer the second one. Okay, so you've been taking it prolonged. Will you develop tolerance or desensitization? So methylphenidate is actually a controlled substance. So yeah, you can certainly develop tolerance and dependence with that. Atomoxetine is not, it's not a controlled substance. However, it is a psychotropic medication, so it may take longer to develop something called neuroadaptation, which can look similar to like a dependence, but it's when your neurons become desensitized to the effects of the medication. Now, atomoxetine can actually be used as needed, just like the other stimulants are used for some people, that they can get benefit using it like Monday through Friday for school or for work, and then take breaks on the weekend, just like you would with like something like methylphenidate to help lower the risk of that neuroadaptation. So that is something that you could certainly do. And there was another question you had. Okay, yeah. You're on atomoxetine. Can I add magnesium and L-theanine supplement? Will I get additional benefits on focus concentration? So yeah, you can. The only thing with magnesium is, which is rare. You can get too much magnesium that can interfere with heart rate and blood pressure, or if you're on blood pressure medications, can be a factor there. But for most people, as long as your kidneys are functioning well, that's not going to be a huge concern. So yes, you could, for most people, you can safely add magnesium, and L-theanine works on GABA, so can really help with anxiety, but also with focus and concentration. And if you have that type of ADHD where you're a little restless, or you have a little bit of the fidgety type symptoms and a little bit of anxiety there, then these two would really, really work well. If you're just looking to gain more focus and concentration, what actually can really work well would be green tea. Now, I know green tea has some caffeine in it, but you wouldn't overdo it, because you don't want to exacerbate some side effects with caffeine on the atomoxetine. But it has ECGC, so you could also look at supplements that have that as well. But drinking a glass of green tea in the morning would actually be very helpful. And I'm talking about like the herbal green tea, not like the sugary, green tea that a lot of products companies make. So like an herbal tea, that would actually be a clean form of caffeine, but also provide you with really good benefits for focus and concentration. I like to drink green tea, with a little bit of honey, before my sessions here live, because it helps me to bring things to remembrance with all these questions that you guys throw at me. So yeah, very, very helpful. Thank you for that question. Oh, hi. Oh, thank you, Nurbama. I got a super chat. I did not forget to bring my super chat thing here to play. So, oh, there we go. Well, thank you so much for the support. I really appreciate that. That's my little video for the super chat. Prestique was in green and she wants to cross taper me. Okay. So Prestique is the cousin to venlafaxine. It's desvenlafaxine. So if you are tolerating venlafaxine or Effexor, getting some benefit, but maybe not enough. And maybe it's because of the way you're metabolizing it, that you're not able to increase or gain any benefit. Maybe you were having increased anxiety when you were trying to increase the venlafaxine. Switching over to Prestique is a good choice. And being that's in the green, you're going to have a less risk of these types of side effects that you can get with the venlafaxine or Effexor. So yeah, that's a very good choice then. Good to hear. Hi, Joey. Did Symbiox get approved just because of the metabolite norfluoxetine, kind of like norquetiapine, which got it approved for MDD adjunct? I'm not sure why Symbiox got approved, if it was because of the metabolite or not, because it is just combining fluoxetine with olanzapine, and providers have been doing that for years. But I don't know the logistics of it, as far as how they were able to stick a new label on it and get it the pharmaceutical companies are very crafty with that. They want to line their pockets, obviously. And so yeah, that's a very interesting question. It may be because of that, as far as that's concerned, but I really don't know exactly why. Hi, Prith Virha. I take 5 milligrams of escitalopram and 2 milligrams of aripiprazole. I'm guessing that's aripiprazole. 25 milligrams of Prestige and feel very happy and well. My question is whether I will have to take them for lifetime. Well, it depends. You know, if you go back and look at, I have a video on skills before pills, and I mentioned this whole long term. You a lot of times you need the pills to leverage skills, like to get yourself unstuck. So it would really depend on why you needed to be put on these medications to begin with. What were the underlying root causes, and were those root causes resolved? And this includes life stressors and things of that nature. Did you do the work in therapy? Are the life stressors no longer there? Are you learning to cope and manage your anxiety symptoms and depression symptoms? And then you can talk to your provider about it. Now, when you're on 3 different medications, it makes it a little harder to try and come off. So I'm not sure why they kind of added all these different medications and they're all at low dosages. Because typically we maximize one medication first before we add others in, unless there's a specific reason, like if you were having maybe some psychotic effects, maybe we would add in something like an antipsychotic like Abilify. Now, I would never use 2 antidepressants like an SSRI and SNRI, just because that's super high risk for serotonin syndrome and not in clinical practice guidelines. So that combination there, though they're both low dosages, so maybe there is some need to leverage some norepinephrine there, but very risky. So when you're thinking about lifetime or lifelong, when I work with patients, when I put them on medication, and even if I decide we need to adjunct for some reason, if this is their first time, we talk about skills, get them in therapy, help them to develop, refine their skills. And then at the 6-month point, we talk about, hey, you've been on the medication for 6 months. How do you feel? You're doing great. Like in your case, you're very happy. Well, how do you feel about tapering off? And so we would start that conversation at that point. And most patients want to try to taper off. And it becomes bit easier if you're on it shorter term, like 6 months versus years. So then at this point, if I was looking at someone with these 3, I would want to taper off of Prestige first, just because it's one of the hardest to come off of. And you'd want to have the other 2 kind of there to support, the neurotransmitter deficits that could occur. And then second, I would do the Lexapro, and then do the Abilify aripiprazole last. So that's how the approach that I would take if I were to try. And as you start coming off, you would stay in sessions with your provider. When I start tapering someone off, I want to see them every 2 weeks and see how they're doing. Sometimes, for financial reasons, I may go for 4 weeks. But I really want to keep a close eye on them to see how they're doing through the taper process as we start removing medications. And if things come up, we address them and go from there. And a lot of clients, once we address their root causes and they're doing really well and using their skills, we are able to taper them off of their medications and then they're medication free. So those are the best case scenarios. So this is your first bout of depression or anxiety, and this is kind of the medications you are on. It's been 6 months or longer to have that conversation with your provider to see. Now, if you do, if this is a chronic thing that's happening over and over, I don't want to stigmatize using medication. So like if it is something that you're dealing with chronically, and this is maybe a second or third episode, and maybe that's why you're on these combinations of medications, you do have to take caution when coming off of them. a little more in that regards, and perhaps you may need to be on medication lifelong. There are a small percentage of patients. It's not as large as the pharmaceutical companies want us to think it is, but there are a small percentage of patients who have a lot of different genetic components that just really make it difficult for them to deal with, depression, anxiety, or that just have it out of the blue. Like, will just have depression. Everything's going great in their life, and they just have depression out of nowhere. And so, in those cases where it's harder to manage, even though you treat nutrient deficiencies, you are, your lifestyle's great, you're eating great, you're doing your therapy, etc. You may still need medication. And so there's nothing wrong with that either. It's just that it's important to know that medications have their limitations, and make sure that you understand the side effects, and also the risk of, if you have to come off of them eventually, that there may be some withdrawal symptoms. So always talk about that with your provider, and make sure you taper off safely if you decide to taper or cross taper to a different medication. Okay, Ganesh again. Hi, ma'am. How much difference you see in quality between branded versus generic? Yeah, I had answered this earlier. Um, Not much difference for the most part. So, what I mean by that is most people will be able to tolerate a switch from brand versus generic, but there are some people who are just sensitive to those components in the generic formulations. So maybe the dyes, the fillers, whatever else the generic formulas have that may be a little different than the brand. Some people may react to that. Rohit, hello. Is medication necessary for obsessive compulsive disorder? Can it be treated with exposure and response preventive therapy only? Absolutely, can be treated with therapy only, and different forms of therapy can work. Exposure and response prevention therapy can be a very good way to treat OCD. And yes, therapy alone can be effective. Some patients do need medication support, especially if they're having significant symptoms during therapy, during the exposure piece. So that this is a really good example of, sometimes we need pills to build skills. So maybe you may need medication for a little bit just to help get you over the initial phases of the exposure, and then you taper off as you start becoming more comfortable with it and start to adapt. And a lot of the changes that are happening in therapy are due to brain-derived neurotropic factor and neuroplasticity that's occurring. Your brain is learning how to deal with the uncomfortable sensations, feelings, compulsions, thoughts that are going on with whatever it is that you have the obsession for, and then the compulsive behavior that is the thing that you do in response to those obsessions. And so, doing this exposure and response prevention therapy really helps to rewire the brain, and helps you to lessen the intensity of that anxiety, because OCD is an anxiety disorder. So yeah, very, very helpful. And you can do that alone. You don't always need medication, but sometimes you do. Okay. Noah, hi Noah. Can I take Wellbutrin if I have schizophrenia? Well, so there is a risk with Wellbutrin in patients with schizophrenia and even bipolar, because it's acting on dopamine and norepinephrine. So you have to do it cautiously. The risk is that, the psychotic features of both of these illnesses, schizophrenia and bipolar, are a result of, too much dopamine, and like the meso limbic cortical areas of the brain. And so when we then increase dopamine in certain areas. Now, with buproprion, it's mainly the prefrontal cortex. So if you're having cognitive symptoms of schizophrenia, or even some of the medications can make you feel like flat or blunted, using bupropion can be advantageous in those cases, but you would want to do it cautiously, maybe a little slowly, because there is some risk of increasing dopamine in those areas where it may exacerbate, psychosis. So as long as your schizophrenia is managed well and you're not having psychosis and you're stable, but maybe you're having significant depression, flat, presentation of affect, just a little bit of bupropion can be beneficial. Um, Another reason why it would not be considered, or maybe your provider may not want to use bupropion, is if there's a seizure history. Um, Seizure risk goes up and it increases when you adjunct with antipsychotics. So that is also something to remember there. So, though generally speaking, you could do this with caution, some providers are going to say, well, no, because you have all these other risk factors, and seizures would be one of them. Blood pressure could be another one. So someone who's sensitive, hypertensive, and sensitive to norepinephrine, and that can increase their hypertension and things of that nature. So, yeah, so a conversation, should be had with your provider. It can be done, but done cautiously, keeping in mind some of those reasons why we wouldn't want to use bupropion or Wellbutrin. Hi, Joey. Um, AM 10 milligrams Adderall IR, PM 20 milligrams Lexapro, 50 to 100 milligrams Seroquel, and PRN clonazepam. I constantly have symptoms of autonomic arousal. Okay, I need a stimulant for my ADHD. Would propanolol help? Um, you know what? With ADHD, with autonomic arousal, actually clonidine, I don't know if you've tried that, can be helpful, but you're on clonazepam PRN. Um, yeah, clonidine, you're on quite a bit of different medications here, so you probably have more going on than just ADHD. The reason why, because clonidine, Capve is the form of clonidine that's used for ADHD, and so that's why I said clonidine over propanolol, but similar mechanism of action there, so it could be helpful in reducing autonomic arousal. Yes, especially if you have problems with increasing heart rate and blood pressure. So either propanolol or clonidine, but clonidine could actually be advantageous just because it also has been studied and has benefit for ADHD altogether. So it could be something to look into. Hi. Giselle, I appreciate your practice so much as you focus on holistic approach, but recognize that medications also have their place. Yes, they certainly do. They do have their place in certain circumstances. That's why I do an integrative approach, and do focus heavily on holistic approaches more than medication approaches, but certainly do integrative. Thank you. Elias, Sonengrad. Hello, Elias. I remember you from before. Is caffeine coffee good for mental health? Well, in moderation, and it depends on the kind. Like I said, with caffeine, I really like green tea. It's a cleaner source of caffeine. It's not as high as caffeine as you can get in some coffees, and 1 cup would be right the limit. What people tend to do is then they overindulge, right, and then they start becoming dependent on caffeine, right, and it's a drug, it's a stimulant, and so it can also have side effects, and some people can become dependent on it, and they have withdrawal headaches and problems when using caffeine or coffee for too long. So I like to leverage caffeine, particularly like I mentioned earlier, green tea, as needed for situations where I feel like I need a little bit more focus, a little bit more, maybe some energy, some attention. And coffee can be utilized in a similar fashion. You just have to be careful with coffee because, obviously, if you're getting it at Starbucks with a bunch of sugar and cream and, things like that, the calorie consumption, the inflammatory load there, if it's just, good organic black coffee, I mean, that might be a better choice. And you're just doing 1 cup in the morning to kind of give you that boost. that may be just fine. So it's all in moderation. What works well for you and how you respond to it, I guess, is really the answer there in general for people. Thank you for the question. Skelly MC, hello. Hi, why would medication suddenly stop working and why does it take time to work? Is it because the brain and nervous system is trying to get used to the new homeostasis made by the drug? Yes. So, good point here. It does take a little while for our brains to adjust to, it's called neuroadaptation. That's occurring there. But when the medications suddenly stop working, a lot of times it's because of something called downregulation, where the set point, the homeostatic set point and neuroadaptation has occurred in the brain. And so, for instance, with SSRI, serotonin, so you're in essence blocking your reuptake release of your own serotonin, allowing more to be in the synapses. And so downstream, what happens is your body, you stop producing serotonin because you want to maintain this balance, because you can overdo it and you don't want to go into serotonin toxicity. So there's some checks and balances there. And so at some point, it seems like the medication stops working because of that neuroadaptation. Now, another reason that I want to bring in, again, here's my holistic approach, but it could be because you're missing cofactors and nutrients, which is why it's always important to make sure you're looking at your labs. And when I say your labs, look at my video, Basic Labs for Mental Health. I'll have Raul, if you can find that, put that in the chat. Because you want to make sure that you're ruling out nutrient deficiencies, and especially those nutrients that are considered cofactors for making serotonin. So if you don't have enough B12, B9, omega-3s, iron, vitamin D, magnesium, zinc, these are all important cofactors, minerals, molybdenum, that's required for this whole process of how you take your food. You eat a piece of turkey, has tryptophan in it, and how it converts to 5-HTP, the type of serotonin that can cross the blood-brain barrier, requires multiple steps, and it requires nutrients for that process to happen. So if you don't have enough of these nutrients, then that can lead to this actually much more quickly. And then if you just go down the path of conventional approach, just keep adding and adding and adding and adding medications without addressing the root cause, you can end up treatment resistant. So it's always important when you get to this point that you, or before you even get to this point, if you're going to start medications, before you start medications, please check your labs, see what's under the hood, make sure you're ruling out things like, problems with nutrients, thyroid imbalances, hormone imbalances, inflammatory markers. Always check homocysteine with B vitamins. Please ask for it, because checking your B vitamins without homocysteine makes no sense at all. And if you don't know what I'm talking about, look at my video on the MTHFR gene. Very important video that describes why we need to check homocysteine, because you could look like you're quote unquote normal in those B vitamins, but still actually have a problem methylating them. And they could be developing this neurotoxic chemical called homocysteine, which makes nothing work for you. And you have lots of reactions to things. So I think that's important to note too. So conventional, like, psychiatry will say, oh, it's just this neuroadaptation. It's just keep adding and adding and adding. But we need to look at this and take a step back and say, actually, we need the cofactors as well. We can't ignore that at all. And unfortunately, the standard American diet depletes our body of the nutrients that we need. So there's a lot of people walking around here with significant nutrient deficiencies that can be corrected. And there are people who need supplements long term, maybe because of their genes. They can't, like MTHFR, VDR is another one, vitamin D receptor gene. Those patients, they need to be on high doses of vitamin D lifelong. And there's other genes like that as well. But anyhow, yes, medications can stop working. Yes, homeostasis has something to do with it, but we can't ignore the cofactors and the nutrient deficiencies that are involved in making these neurotransmitters to begin with. So serotonin, norepinephrine, dopamine, all of them require specific cofactors to make them, for our brains to make them to begin with. Okay. Ganesh, hello, ma'am. Again, I am already taking atomoxetine 10 milligrams for the last 6 days, and it increased my blood pressure. Oh, yeah. 140 over 90. Should I stop? And BP will come down. Yeah. So an increase in blood pressure is a side effect of atomoxetine. It's primarily because of that norepinephrine, specifically increasing that has this risk. So talk it over with your doctor. Yes. If this is related to just the medication, which it sounds like it is, when you stop it, you'll see that your blood pressure will come down. Usually by the next day, you should be able to see that blood pressure go back to normal. So you can discuss this with your provider and decide on next steps on what to do, as far as maybe switching to something different or maybe adding something like clonidine to help with managing the blood pressure and also helping with the ADHD symptoms. Okay, next question. Mad X Toy, what is propanolol exactly used for? Propanolol it has a lot of uses. So it's actually a hypertensive medication, an antihypertensive. So it's primarily used for people with high blood pressure and also for people with increasing heart rate because it's a beta blocker. Now, its role in anxiety is in the fact that it actually blocks beta 1 and beta 2. So with propanolol, folks who have asthma, you have to be careful with it because it can constrict the bronchial and exacerbate asthma and or make your inhalers not work. So keep that in mind. But the way that it works with anxiety is on this alpha adrenergic system. It works on that as well. The beta adrenergic system. So what we're doing is centrally speaking, we are tapping into that sympathetic activation. And so we're turning it down. And so that's how it works with anxiety. So the way I use propanolol has nothing to do with its cardiac uses. I use it for anxiety in certain cases because it can really help to turn those symptoms down that people have that have this reaction to a fear response or stress, and they feel a little bit maybe sweaty. They have some increasing heart rate. They feel a little shaky. Giving a little bit of propanolol can help bring those symptoms down. And it also has a little bit of a calming effect because of how it's working in that sympathetic nervous system and that signaling that goes on centrally speaking. And so, yes, it can help lower heart rate. It can help lower blood pressure, which oftentimes goes up with anxiety, but it has that little bit of calming effect as well. Now, another thing with propanolol that I found interesting when I was preparing my video for it is that they did a lot of studies with it in veterans, and they found that it actually decreases the fear response with long-term use. So it's actually a medication that's commonly used for folks with PTSD because of that. It decreases that arousal, that fear response. So yeah, propanolol can be used for many things. FDA label is going to tell you mostly the blood pressure, heart rate, and a lot of other cardiac things that's used for. But off-label use can be used for generalized anxiety, social anxiety disorder, and a lot of other, like I mentioned, PTSD, etc. Anything that's activating that sympathetic fight or flight nervous system. Chantal Sign, hello. Which antidepressant works best with vortioxetine and depression and acute psychosis? Acute psychosis, and okay, so I'm guessing you're on vortioxetine for depression, and maybe that's helping, and you're having some psychosis. So you wouldn't add another antidepressant with vortioxetine. If you're having psychosis, so sometimes a severe depression, you can have psychosis. Now, you want to make sure that you are evaluating whether or not, like with a provider, whether or not the psychosis is actually due to depression as a, issue with depression, or could this actually be schizophrenia or a bipolar presentation? I mean, that needs to be differentiated, first of all. But when you're looking at, even if it is a depression with a psychosis or psychotic features, we would call it, you would add in an antipsychotic to treat that. So you would not want to add in another antidepressant to work with vortioxetine, because remember, vortioxetine is a very powerful serotonin modulator. It's a multimodal serotonin-based antidepressant. It works on a lot of those neurotransmitters. And so if your or the psychosis became present after using vortioxetine, it may be actually because it was too stimulating, and maybe there's an underlying bipolar or schizophrenia presentation happening. If it's due to depression still being present and you're in a psychosis state, you would want to look at adding in an antipsychotic. Now, typically, when we're looking at adjuncting antipsychotics, ones that are used very commonly are the Rexulti, it's branded, Vraylar, branded, Latuda, not branded anymore. Abilify, of course, not branded, but that one, has risk for akathisia and things like that, but that can also be used. Now, there are others that are Seroquel as well can be used adjunctly. The older ones, olanzapine, can be used. You could really utilize any of these in really low dosages for a person who's depressed with psychotic features. And then, after those features stabilize, then you can taper them off. Usually within 3 months or so, a person can stabilize with that. Now, what I want to say about vortioxetine is that you have to be careful with drug interactions. So make sure you're doing the drug interaction checker, because off the top of my head, I can't say for sure which one of those antipsychotics would potentially interact with it. And in the description of all my videos, I have, under useful resources, a link to the free drug interaction checker by drugs.com. I like that one. It actually gives a professional synopsis of it. It gives, layman person synopsis of like what, or summary of what interactions, with the medication. So you can put both medications in and kind of look for yourself there as well to make sure that you are looking for potential drug interactions. But yeah, anytime someone is on an antidepressant and they develop psychosis, we want to rule out bipolar, rule out schizophrenia. And if it is still looked at as that, those are ruled out, and it's a psychotic feature of depression, you would add in an antipsychotic, very low dose. If it turns out it's actually bipolar or schizophrenic presentation, then you would still use the antipsychotics, but you may need larger doses to bring the episode of psychosis down or to ameliorate it. Hi, Skelly. Good point. Thanks. You are low on vitamin D. Might be the reason vortioxetine worked great 3 weeks start and suddenly it stopped working. My rest of the blood work is fine. I eat healthy otherwise. Yeah. So with vitamin D, we want to optimize that, especially if you're having symptoms of depression. So what I mean by optimize is you want to be 50 and above, like 50 to 100. Some providers will say 60 to 120. 50 to 100, I think, is good. So, so if you were already low, that means you're probably below 30. So you're really, really low. Because anyone that's below 50, to me, they're getting vitamin D. And even if the other thing people say, well, I'll just go out in the sun more. Well, good luck with that. Because it takes a while to get out in the sun. It's a process for your body to synthesize it. I mean, you could certainly try it, but most people, when you're low in vitamin D, it's because there's some genetic factor, some issues there. Unless you're inside all the time, I mean, if you're going out a couple of days a week and you're getting at least 20 minutes of sun exposure, your body should be able to synthesize and make vitamin D. If you're not able to get that, you can try to increase decrease it, and then I would recheck in a couple of months just to see if it's gone up. Most likely, though, it won't go up, just because a lot of the foods that we eat, like I said, especially if you're eating standard American diet and non-organic, glyphosate is a factor there with binding to a lot of the nutrients that we need, and even vitamin D. And then there may be some genetic reasons why you're low. So vitamin D is tends to be a staple supplement for many people who are not only low in vitamin D, but also are dealing with depression, and even anxiety can be a factor, but typically it strikes as depression. There are some studies that show a connection too between low vitamin D, and these are significantly low vitamin D, and psychosis. So that is also something I've seen several studies demonstrating that correlation or connection there. So always good to make sure you're getting your labs checked. So if you were low on vitamin D, definitely look into supplementing. And when you supplement with vitamin D, D3 is best. Combine it with K2, because K2 is going to help to bring it into the cells where it's needed. And then always take it with food. Hi, Joey. 20 milligrams Lexapro with 50 milligrams adjunctively for bipolar depression helps a lot. But I also have ADHD, so the Adderall morning dose is needed. Would magglycinate help with physical anxiety symptoms? Yeah, like I mentioned earlier, magnesium glycinate can be very helpful with the fidgety physical symptoms of anxiety. Magnesium is very beneficial for the stress response. It has over 300 enzymatic reactions. I have a video specifically on magnesium if you wanted to get into more of the details on that. But, with magnesium, the reason why I like to use magnesium in patients, especially when they have anxiety, is because if you have anxiety, most likely your stress response is overactivated. And when that happens, that HPA axis requires a lot of magnesium. That whole stress response signaling requires a lot of magnesium. So it's going to steal magnesium from your cells. So you're most likely, when you have anxiety, you also are low in magnesium. And so using magnesium glycinate can be helpful. Now, even if you're not low in magnesium, magnesium glycinate can still be helpful. I mentioned in that video too, with the testing for magnesium, very hard to determine deficiency with blood testing with magnesium, because most of the magnesium is in our cells, not in our serum or our blood. You could do a magnesium serum and magnesium RBC to get general picture, but then I like to further break it down to optimizing those levels. But even so, if someone is optimized in magnesium, but they have a lot of stress, they're using a lot of magnesium. So using a little bit can still be helpful. And as long as your kidneys are working well, you should be able to detoxify or get rid of the excess magnesium if you do end up with a little bit of excess. Okay, next question. Noah, hi. Which is better for anxiety, hydroxyzine or propanolol? Well, it depends. Both of them are good for anxiety. Hydroxyzine is the only one that's FDA approved for generalized anxiety disorder. The thing with hydroxyzine is that a lot of people, yeah, it can be very helpful, especially if most of your anxiety is at night and trouble sleeping, because it's sedating as well. But a lot of the trouble that people have with hydroxyzine is that it's too sedating for them. And they'll say it just made me feel too groggy, like I couldn't, function. So then that's when we would maybe try and lean towards a propanolol. So yeah, either or. It depends on the person. It depends on why we're wanting to use the medication. So in a grand scheme of things, if you're just looking at the research that's out there, people will say, well, hydroxyzine, it's FDA approved. It's tons of studies to support it. But not everyone can tolerate hydroxyzine because it is so sedating for most people. You could use a little bit if that happens, like a 10 milligram hydroxyzine HCl, but that may not be enough. Typical doses for Treating anxiety is going to be, 50 to 100 milligrams, which a lot of people, like I said, can't tolerate that high because it makes them sedated. So some people also will respond to 25 milligrams, but again, just depends on what you can tolerate. Hi, how would you dose daily propanolol? If I found that 40 milligrams is what helps. No response to lower doses. You could dose 40 milligrams in one single dose is fine. You could do extended release as well if you need it throughout the day. If you're just trying to, Joey, minimize the effects of that Adderall and what that's doing to you in the morning, then just once a day dosing. If you're requiring more of that throughout the day, or your symptoms last throughout the day, then you may want to look at an extended release formulation of 40 milligrams. With propanolol, you can go as high as 120 milligrams. So, 40 milligrams at a dose is in a day is completely fine. Hi, Camille. I've got bipolar, done labs and CBT therapy. Nothing worked for years now. I'm stable, but I take a lot. Lamictal, Zyprexa, Cymbalta, Remeron, and Lyrica. Okay. Do you think it will be lifetime long? Well, with bipolar, this is a little trickier. A lot of other mechanisms going on besides a lot of the nutrient deficiencies that I talk about. So always good to rule those things out. Another thing too with bipolar presentations that people don't talk a lot about is something called pyroluria, which is when you have too many cryptopyrroles, which deplete your B6 and your zinc. That can actually look a lot like bipolar. So get that done too. It's not a common test. The cryptopyrrole, it's a urine test. But make sure you do that too, because that's certainly not something that any conventional doctor would order. It would be something you'd have to like look up on your own and kind of, order it and get that done just to make sure that's not a factor. Okay, so that aside, um, when we're looking at all of these different medications, you certainly are in a place where you most likely will need these lifelong. Is that a bad thing? As long as you're stable on it. Like I said before, I don't want to stigmatize using medication and make medication out to be the bad guy. I just want to make sure that you are optimizing your own nutritional health, and making sure that you're optimizing the way these medications work. So perhaps you may need lower dosages and may not need to keep adding on to this list. So when you do labs, making sure that you're looking beyond basic labs and you're doing your B12, B9, zinc, folate, which is B9, sorry, vitamin D. I also look at copper when I'm looking at that. And of course, I mentioned magnesium, serum and RBC, magnesium, and along with the other labs I mentioned, looking for different hormones, DHEA, for sure for adrenals, especially when you have bipolar. And then I mentioned too with bipolar, it's not in that video for labs, but because it's something odd that would but could be a presentation, which is cryptopyrroles. So that is something that I would let my patient know who has bipolar to look into that, because it could be that type of presentation. So just making sure you're looking at that. Another thing too, lithium, that's another one in a hair test. You can check lithium in a urine test too. Hair test is more uh, accurate, and going to give you reflect more of what's in the cells. That's another way to look at magnesium too, and these other minerals, like zinc and copper, etc., and even look for heavy metals. But it's hard to predict. I don't know your whole story if this is something you've been on for many, many years. But it is possible that maybe you do need lifelong support. Maybe if you dig a little deeper into your labs and some root causes, and you start treating some of those things, that you may be able to reduce some of these, because you're on two antidepressants there, you're on two mood stabilizers, Lamictal, Zyprexa, and then you're on Lyrica. I don't know if that's for pain or for anxiety, but all of these things are working in different capacities in the brain, and I'm sure they're probably helping. You said you're stable now, which probably took a long time to get there. If these are the medications you are now on, but always look at those underlying things. But if this is where you're at and you feel like you're stable, then there's nothing wrong with having to be on them long term. Hi, Ganesh. Ma'am, what's your view about Nupept and Cimax? Um, those are not medications that I'm familiar with. Maybe because that's another country, and they may have another name that I might be familiar with, but I am not familiar with these medications in that spelling or whatever. I don't know. So I'm sorry about that. Okay, 0 day. Hello. I'm using alprazolam, clonazepam for more than 4 years. I recently read somewhere that long-term usage of benzo can increase the risk of dementia. How can I avoid it? I can't quit benzos. Try. Thank you. Help me. So yeah, good way to decrease your risk for dementia, Alzheimer's presentation. Omega-3 fatty acids, very, very protective. Lots of studies on that. So when you use omega-3s, you want to use 2 to 3 grams. So that's 2,000 to 3,000 milligrams when you're using it for brain health, to support brain health, for depression, anxiety, anything related to the brain. You need high dosages like that. Okay, so that's certainly going to help be protective there. Look at your nutrients, making sure that you're repleting your nutrients and you're getting enough of these nutrients in your diet for brain health. So doing those labs would be helpful. As a blanket, I like to do omega-3s and even low dose lithium orotate. Very, very anti-inflammatory and very brain protective. And it's a nutrient that is getting a lot of publicity in the research for being preventative for Alzheimer's and dementia. So, just lithium orotate, not lithium carbonate, prescription, but like 1 or 2 milligrams of lithium orotate can be very protective for brain health. And so that with omega-3s, you could do zinc and magnesium and all these other nutrients I was talking about. But I would first want to check, making sure that you need those nutrients. Vitamin D could also be very neuroprotective, if especially if you're low. So check your nutrients, but generally speaking, omega-3s, not going to be harmful. A little bit of lithium orotate, 1 to 2 milligrams, not going to be harmful, but very helpful and protective in preventing this dementia. And then look at labs, making sure you're not deficient in those other nutrients, and replete, if you find them, and then making sure your diet is not inflammatory, because really it's the reason why dementia, Alzheimer's, diabetes, all that is on the rise is really because of what we're eating. And the processed foods, greasy, fried foods, sugary foods, if you're on a high carb diet, that's going to be inflammatory. So just make sure that you're eating more of maybe an anti-inflammatory like diet, whole food diet, organic foods, whatever works for you. Some people say keto, which is great. Lots of studies to show it's helpful for brain health and also can help with dementia symptoms as well and be very protective, but not everybody can do keto. So it's what you can tolerate. It's what um, you can sustain as a lifestyle and what will work best for you. But certainly cleaning up your diet would be foundational, and making sure you're getting exercise, even if it's just walking for 20 minutes a day. Very helpful for brain health as well. So good question. Hello. I've increased it from escitalopram 10 to 15 milligrams now, and my anxiety and depression gets worse at first. Is this also a side effect? Yes. When this happens, it can be a reaction at first. I mean, restlessness, agitation, that kind of a feeling can be a side effect of Lexapro and the SSRIs initially. Tends to get better. Um, the first week or 2 max. If it's not better than that, it's more of an adverse effect, and I would be looking at maybe a different, medication. But it also makes me wonder if, you have problems with methylation that can present like this, that they tend to get worse anxiety or these types of side effects. So I would say that, um, make sure you're doing your labs, looking at homocysteine in particular, because I see this commonly with elevated homocysteine and someone who has MTHFR, that they react to the SSRIs or even, other medications in a way that, looks like an anxiety presentation. So just make sure that you're replenishing your nutrients and checking for those things, in particular, homocysteine, B12, B9, in your labs. Okay. PB, I'll just say. Some of these names are hard for me to pronounce. Okay. Hi. I love your videos so much. I have schizoaffective disorder and I have been on Seroquel for 8 months. What are your thoughts on long-term use of the drug? Is it safe? Yeah, Seroquel, in my video, I talk about how it's very, useful. It's very versatile. And obviously for schizoaffective disorder, um, very good medication because it's actually used for bipolar and schizophrenia and can be a standalone treatment. So using Seroquel alone in the proper dosages, you're probably doing the XR, I imagine, can be very, very helpful. Now, the long term, this is something you have to watch out for with Seroquel, like I mentioned in the video, is metabolic syndrome and making sure you're looking at your labs. So making sure you're checking your lipid panel, making sure you're looking at your glucose and hemoglobin A1C, which are markers for diabetes, which metabolic syndrome is like a precursor to insulin resistance, which leads to this diabetic state. So that's something you want to be aware of. Now, not everybody who's on Seroquel long term ends up with metabolic syndrome. It's just there is a large percentage, so it is something to be concerned with. So as far as safety goes, that's one of the main things because it's one of the most common long-term risk. There are many other risk of taking Seroquel that I mentioned in that video, precautions that you have to look out for. So make sure that with seizures, it can lower seizure threshold. So that may or may not be an issue with you if you have a history of seizures or not. Other things are cardiac, so blood pressure problems. If you have orthostatic hypotension, make sure you're changing your position slowly. Make sure you're hydrated, you're staying hydrated. And like I mentioned earlier on the patient who was talking about those benzos and helping to reduce the effects of dementia, when you're on something long term and you want to lower the risk of some of these side effects, especially metabolic syndrome, omega-3s are also going to be helpful there. Cleaning up your diet, super, super helpful. Looking at more of an anti-inflammatory diet approach. Just get rid of, all the standard American diet crap, and eat cleaner. And then exercise. So all of those things can help mitigate, lessen the impact of this metabolic syndrome. So if you do need to be on it long term, then certainly make sure that you have these things in place as part of your lifestyle so that you can prevent some of these long-term effects from the medication. Good questions today. Hi, Noah. What is better for long-term usage, Lyrica or gabapentin? I'm on 2,400 milligrams of gabapentin. Well, okay, now this is a little different. If you ask me about the GABAergic drugs, those are very, very difficult to come off of. Seroquel is usually not. If someone has a problem coming off of Seroquel, they most likely have a lot of other things going on, especially with their cofactors. But cofactors or not, with GABAergic drugs like Lyrica and gabapentin, they act very similarly to the benzodiazepines. So in my opinion, none of them are good for long-term usage because of this risk of developing this adaptation, the dependency, and then eventually, if you have to taper off, very, very hard to come off of either of them. Um, in some states, like for instance in Florida, gabapentin is not considered a controlled substance, but Lyrica is. Um, so there is more of a risk with Lyrica with dependency, but there are other states, say you're in Kentucky, they will consider gabapentin a controlled substance. So because it can have this similar issue with dependency, but Lyrica certainly has a greater issue with that than gabapentin. So I guess if you're looking at it in that regards, I would say gabapentin. But and I know that's a high dose, but I'm pretty sure you can go up to 3,600 milligrams of gabapentin safely, which I know is high, but that from my recall, I'm pretty confident that 3,600 milligrams is the max on gabapentin. So 2,400, you're not at the max yet. So I wouldn't worry so much about the dosage in milligrams. Lyric, obviously, the doses are going to be smaller, but even if you're on, like people say, it's a low dose of Xanax, 0.25, you can still end up with problems. You can still end up with issues with tolerance and withdrawal, etc., down the road. So the dosage is really not the issue. The issue is really the dependency, tolerance, and if you ever need to come off the medication, or if it starts creating issues with, like GABAergic drugs do, like the benzos, with memory impairments, with balance problems, and things of that nature, or any type of neurological problems, then you figure you have to come off of it. It can be, both of these can be difficult to come off of, but I always have this handy here lately. The Maudsley Deprescribing Guides can be helpful. It has the gabapentin drugs in there. It has tables for both, pregabalin and gabapentin, on tapering them, and schedules to use. So if you ever need to go there to taper off, definitely I recommend, getting this book, reading it. I'm pretty sure $38-40 max, I think, you for the book, but very, very useful if you have to taper off medications. And that's also one of the resources I list in the useful resources in the description as well. But yeah, I would say neither are good for long-term use in my opinion. But if you have to be on them, just hope that you don't end up in that tolerance dependent state and have to come off. Hello, Ganesh. What's your view about nootropic peptides? Yeah, so nootropic peptides, there's a lot of them out there, and there are a lot of people who can benefit from these types of different nootropic medications or peptides. There's different herbs that they classify as nootropics, and nootropics just mean that they're working in the brain. So they can help for a lot of people, but just like I said with medications, you're basically using these peptides and these herbs that they call nootropics as drugs, right? Yeah, there's certainly the safety profile certainly a lot safer than the pharmaceuticals, definitely. So I'm not going to argue that at all. However, we have to look at, when we're looking at using herbals, nootropics, peptides, etc., to leverage some effect in the brain, especially a lot of people with ADHD will use these nootropics. That you're trying to get a benefit to enhance dopamine or enhance, brain function, when really um, we have to always go back to those cofactors, because you're basically doing the same thing like I talk about with the medications, that if you just go to giving yourself medication without doing your due diligence and making sure that you're not needing nutrient cofactors or needing that support nutritionally, or ignoring that you eat a bad diet, ignoring the fact that you don't exercise, etc., they're only going to work to a certain point or may not work at all. So always consider those cofactors and nutrient deficiencies first, because that's foundational. Um, I talk about it in my basic lab video, and I also talk about it in a video I did about micronutrients to treat depression. I talk about specifically in that video, I think I even show you the cofactors for serotonin, like an abridged version of that, and all the nutrients you need for that. So yeah, and there's lots of studies on micronutrients and what they can do for ADHD. I think that's initially where a lot of the studies came from with micronutrients, was in ADHD in particular. And they found, all this information about them as cofactors, all the nutrients as cofactors. So, but yeah, definitely can be useful, but still need to check your nutrient status. Okay. 14142. Hello. I have zero energy. I'm taking 10 milligrams vortioxetine for the last 2.5 months, though I feel like my body is getting used to it since my energy is a little bit less than a month ago or so. Thoughts. Energy is a little bit less. Okay, vortioxetine for 2.5 months. Okay, so you're having problems with energy. Well, problems with energy can be from a lot of different things. It can be, obviously a symptom of depression when you're looking at, depression as a whole, but why do we get low energy? Well, it could be from low iron, low B12, low B6. So nutrients, right? Keep going back to that. But yeah, it does take some time to get used to vortioxetine, but just make sure that if you're still experiencing this low energy, um, especially when I see someone who's just really debilitating with this energy, like really no energy, I always think, wonder what their DHEA is. I wonder what their adrenal function looks like. Maybe even thinking of doing a salivary cortisol test to look at their cortisol awakening response. Because oftentimes it could be you're dealing with an adrenal fatigue presentation. Especially this would be more so true if someone is anxious a lot chronically, or stressed very, very chronically, and then all of a sudden they crash. That's typically this clue, that this could be happening. And then it looks a lot like depression, but it's actually more adrenal fatigue. So looking at those things, very, very important. When you take vortioxetine, like I mentioned earlier, it is a multimodal antidepressant that works primarily with serotonin, but not just the transport of serotonin. It works specifically on different serotonin receptor sites, both antagonizing and agonizing different pathways strategically, to enhance a lot of neurotransmitters. So, some people, especially with this type of depression, this atypical presentation of, low energy, kind of dragging along type of depression, um, will use vortioxetine to help give them a little bit of energy. Um, and I have to say that symptom is a difficult one to treat just with psychotropic medications, because it's often a cause of these other issues, like I mentioned, adrenal fatigue, or could be low iron. So look at ferritin plus an iron panel, that includes, your iron binding capacity and saturation. And then look at the B12 folate homocysteine. Like I told you before, you don't want to check your B vitamins without checking homocysteine. Um, and make sure that we're ruling that out, of course, along with the CBC, to make sure you're not having problems with anemia. And that's why you're having this significant low energy, because even if this helps a little bit, because it's giving you a little norepinephrine boost, as an effect, that's one of the neurotransmitters it doesn't directly act on, but indirectly, and dopamine. Um, you may be limited in how much benefit you're going to get from it, because you may be depleted in these other areas. So please make sure to check those out as well. But could be, take a little longer. You may need a higher dose to get a little bit more effect. But if you're still not getting, more benefits, I would say, after that 3-month mark, consider increasing. At that point, you're at your max benefit of 10 milligrams. So you may need to increase to 15, if not 20. Okay. Oh, we got another super chat from Ethan Lembry. Hello. Let's get our super chat on stage. Thank you. Thank you. Thank you for the support. All right. Um, Ethan Lembry with a super chat. Opinions on 2 to 3 antipsychotics for one patient. Oh boy. So I don't agree. 3, absolutely not. Absolutely not. My gosh, you're just increasing your risk of side effects when you start adding. 2 antipsychotics, I've seen it done. Not a big fan of it. I'd rather, if we had to use 2 different medications for someone with schizophrenia or bipolar presentation, I'd rather do like a mood stabilizer and an antipsychotic for safety reasons. But I have seen it done with maybe using an antipsychotic that's a little more sedating at night and using one that's a little more activating, for during the day, right? I've seen that done before. Or someone who's on a long acting antipsychotic, maybe we need to give them a little, oral to mitigate the effects of their psychosis. This is more so true with schizophrenia presentations and that more than bipolar. I'm trying to think of any bipolar cases that I've seen 2 antipsychotics, and I can't think off the top of my head, but I can think of several with significant schizophrenia in the community mental health setting. That I worked at a few years ago, that we had to leverage that to help with their schizophrenia symptoms, particularly that were just very difficult to treat. So sometimes that is the case. And the reason why I got out of that type of setting for work is because I didn't have time to do this work that I do now with integrative psychiatry, which is, dig into some root causes. I had someone consultation a couple months ago with a fellow who was, schizophrenic, and he did the lab testing that I asked him to do, thankfully, and I was able to see the results. And he was significantly low in vitamin D. I want to say it was like 10, 11. I mean, it was super low. And I'm like, no wonder, your antipsychotic isn't working well, and you're still feeling like crap. We need to replace this. And so, he talked with his doctor because he was consulting with me, and he wasn't in Florida. So it was just like reviewed the labs. I did my recommendations, sent, something that his doctor can look over along with some of the research I found on vitamin D and psychosis. And he slowly replaced that vitamin D, and lo and behold, started feeling better. So still is on. I want to say maybe it was Iprexa, but anyway, he was still on his antipsychotic, but didn't have to add anything more to it, to get more of an effect. So bottom line is that check your nutrients. Please make sure that before using, 2, gosh, even 3 antipsychotics, I've never seen that, and I would not recommend that. That sounds like you're really setting yourself up for a lot of side effects there. But like I said, I've seen 2, but before I would do that now in my practice, I would definitely want to look at someone's nutrients specifically, but also rule out some medical conditions that can look like schizophrenia presentation as well. So yeah, lots to think about there in that one thing. And I know you asked for my opinion, but that's what it is. And I can really get on a soapbox with these adding medications because it can be very dangerous and lead to a lot of side effect burden for the patient. So just be careful with that. But thank you so much, Ethan, for your question and for the super chat. Edmock, hello. Switched from Abilify to Rexulti for MDD and anxiety, additionally taking buproprion and Vibrid. Okay, wondering if I should be experiencing differences from the 2 since I'm reading that they're similar. Yeah. So when you switch from Abilify to Rexulti, You should notice a difference. Rexulti, if you were on excuse me, if you were on Abilify but you weren't getting much benefit, the logical thing would be to switch to Rexulti, or maybe you were getting partial benefit, is to switch to Rexulti, because it has been shown to be little bit more effective. It works a little differently. I have the video where I compare the two, and I'm trying to think off the top of my head the differences, but nothing's sticking out except for what's sticking out to me is that the side effect profile it favors Rexulti a little more than it does Abilify, in particular with akathisia and weight gain. So if that's why you switch, then yeah, for sure. You're going to get less anxiety, less agitation with Rexulti. Not to say that it's not still a risk, because it still is. It's just a little bit lower of a risk than Abilify, and can be very, very helpful for the MD, a major depressive disorder, and more beneficial for someone with anxiety, because I imagine with the anxiety, you may have been more prone to that effect with the Abilify. It's a little more stimulating. So that could be why your doctor decided to switch you. I'm just guessing from what you're telling me here. But that could be a reason why they may have switched you over to Rexulti. Give it some time. It's not something that happens right away. And, you may need to start at 1 and then go to 2 milligrams. You shouldn't have to go more than that with the Rexulti for the depression side of things. So, so definitely, have the discussion with your doctor if in a month you're not noticing any difference at all. But give it at least a month, give it at least 4 weeks before deciding on, this isn't going to work at all. You should start noticing a difference. But I do have a video about the two if you wanted to look at that video, comparing Abilify with Rexulti, because that could clear things up for you on the differences. Okay, PB, hello. I have actually lost a lot of weight while on Seroquel. I have very little appetite, can only eat small doses of food. Thank you so much for answering my question. Is lamotrigine also safe? Yeah, lamotrigine is actually, as long as you can tolerate it and you're not having those symptoms that you can get, like dizziness, headaches, and some people can get problems with their blood pressure with lamotrigine. If you're combining that with Seroquel, that is safe too, but just to make sure the blood pressure, you're checking your blood pressure, and that's not a factor. The fact that you've actually been able to lose weight on Seroquel is a good factor. The fact that you have very little appetite, not sure what that could be from. But just make sure you're getting enough nutrients, because if you're only eating small doses of food, you may not be getting enough nutrients. So you may need to supplement in that regards. But also look and maybe see a GI doctor to figure out if there's something going on there. But the lamotrigine, yes, lamotrigine, as long as you're not having issues with those side effects, can be something that people tolerate long term. It's something that is used for bipolar, especially bipolar depression, is when I often will use lamotrigine to get benefit. And it's also used obviously for seizure disorder. So people with seizure disorder that do well with lamotrigine use it lifelong, and really no long-term risk. The risk with lamotrigine, the main one that people get all wiry about, is the Stevens-Johnson syndrome, which is very, very, very low risk, and that's only in the initiating, the titrating phase of that. So if you've passed that, and you titrated it slowly, you can really avoid that risk altogether. Then long-term use is safe. You don't increase the risk of Stevens-Johnson's or anything like that with it. So yeah, I'm glad to hear that you're not gaining weight and lamotrigine is safe long-term, but I'm a little concerned about this very little appetite. So make sure that, you're looking at your nutrients, making sure that you're able to absorb your nutrients from food, and that you don't have anything going on there gastrointestinally, and that's causing you to have a little appetite. Okay. Ganesh, hello again. Please make a complete video about meditation. Does it increase concentration and focus, and how much effective right of way of doing meditation, or it's scientifically unproven? No, I actually did a video, Ganesh. I think you asked me to do a video on this last time, and I did a video on it. It didn't get that many views, so I don't know if it was pushed enough by YouTube. Sometimes that happens. Sometimes my videos kind of go into never land. So anyway, Raul, if you can find that video, it's one I did recently, and plug it in there for Ganesh to see that I did, and I actually put all of I went over specifically, I think it was 3 or 4 research articles of meditation, and it was mindfulness based meditation specifically, that goes into, and a couple of them talk about the brain changes that occur. So yeah, it can increase concentration and focus, has a lot of different effects in the brain, and shows improvements in certain areas of the brain. So you can really, you can watch the videos to see those papers that I'm highlighting there, when going over the science behind it. But if you go in the description, the links to those papers should be accessible as well. And I think most of them were open access, meaning you should be able to read the whole article. But if not, the abstracts can give you some information, but the video goes over those in a little more detail. Hello, Caleb Bowling. Is there a medication for borderline personality disorder? No, there isn't. So, with borderline personality disorder, or any personality disorder, there aren't any um, FDA approved medications for it. Now, when we look at any personality disorder, whether it's borderline, or even say someone who has an obsessive compulsive personality disorder, it's not an actual disorder, but it's the personality disorder. And we want to focus on what are the primary symptoms that the person is having a problem with specifically, and focus on, when we're looking at treating, using medication to treat specific symptoms. And oftentimes with borderline personality disorder, it has to do with the ups and downs of their emotions, and their mood swings can be very dramatic, through, in just a 24-hour period, which is not bipolar at all. Bipolar is phases, so time periods of mood changes, not in a day, several different changes in mood. So mood stabilizers can be very helpful there. Low doses of atypical antipsychotics can also be very helpful. But before going to medications, because again, those have a whole list of side effects and issues, right? Make sure you're in therapy. Make sure you're learning how to regulate your emotions, because therapy is first line treatment for borderline personality disorder. And so therapy, absolutely necessary. You could leverage a mood stabilizer, or an atypical antipsychotic at a low dose. Maybe if you just need to do it temporarily while you're learning the skills in therapy to regulate your emotions, could be useful. So the other thing I wanted to mention before it slips my mind is, like I said to the guy with bipolar, is that borderline, especially, this could be more so true with the cryptopyrroles. So this emotional irritability, mood swing presentation, can also be a result of high cryptopyrroles. And so doing a urine cryptopyrrole test will tell you whether or not you have this problem, and it's something that can be mitigated if you do, see a provider who knows how to treat it. But you would need, significantly high doses of B6 and zinc to treat it. So yeah, it's called pyroluria, is the term for the disease with someone who has cryptopyrroles. But it has a lot of mental health symptoms that look very similar to someone who could be labeled borderline or even bipolar, like I mentioned earlier, especially with that irritability and the mood swing presentation. So make sure you rule that out. Make sure you're also doing your nutrient, doing like a nutrient panel, looking at your basic labs for mental health, like I mentioned earlier. I have the video on that, and ruling out some underlying root causes, and that pyroluria can be one of them. So that would be on my radar to want to rule out before even thinking about a medication, okay? Just because there's a lot of risk with taking medication, okay? All right. Hi, Kathy. Please address treatment for low libido due to menopause and fluoxetine 60 milligrams a day and bupropion 60 milligrams a day. Okay, so low libido, you have two things that can be affecting it. Obviously, the fluoxetine, and then now the menopause. So, significant, particularly with patients who are in menopause, this is when I would start looking into bioidentical hormone replacement. That would be the better approach besides using medications. Bupropion can be added with fluoxetine, is often added for people who have a low libido because it's a partial agonist, but it has its limitations. And especially when now you're entering menopause, this is going to be more hormonal than anything. So I would look at doing a Dutch test, seeing a provider who is an expert in understanding the Dutch test, looking at those hormones, and then how to help you through this phase. Dr. Lucretia on she's very popular on Instagram. I don't know that she's on YouTube, but she works specifically in menopause, perimenopause, with women in this stage and helping them specifically with like low libido, and uses the Dutch test and is very well versed in it. So reaching out to someone like her would be, or even looking at her materials that she has available. She may have stuff on YouTube. I just don't know. I just know her from Instagram, and I've seen a few of her. She's done a few educational videos for providers, teaching about the Dutch test and stuff like that. So she's very well educated in this, but definitely that is where more so I would go before trying to leverage more medications or switching medications and things like that. Some providers may want to add something like buproprion, maybe a little bit low dose. That could be helpful. And I have used that before with patients who were not menopausal, but were having problems with fluoxetine and low libido. And they get, better benefits than with the bupropion adjunct. So that could be something. But when it's the menopause, where medication, probably not going to do much. I would look more into what your hormones are telling you, how they're changing, and what we can do in that regards. And even with women like Cialis, you know, may be helpful to help with blood flow in that area, or to dilate the vessels, to help. But again, I would be looking more towards the Dutch test and potential hormone, regulating those hormones a little bit better for you. Okay, next question. Ethan Lembry. Hello, Ethan, again. Yes, I was on olanzapine and Seroquel for 3 months. Okay. Yeah, that's not long-term at all. Olanzapine and Seroquel. Now, both of those are, because you were talking about adding another potentially, I'm guessing, because that's what you said. What was your opinion on 2 to 3? The thing is with both of these is that they both have significant issues with weight and metabolic syndrome. So I wouldn't be suspecting these two because they're both very sedating as well. Unless for some reason your psychosis or symptoms were that severe. So definitely this combination has a higher risk for significant, sedation problems, the metabolic syndrome, 100%, because you combine these two together, very, very high risk. So I would be looking more into what can I do to maybe, nutrient wise, leverage my nutrients and as opposed to being on both of these, and perhaps maybe tapering off one as you start, to feel better or start to fix some nutrient deficiencies that could be going on here. Um, and even like something like lithium orotate, nutritional lithium would be more beneficial. So doing like a hair test to check your minerals, and lithium would be included in a mineral hair test, along with other minerals. But yeah, I would caution you on these two, even though it's only 3 months. It's not a long-term thing. Maybe it was just a temporary thing to get you through a difficult period, and whatever was added last, I would talk to the provider about, hey, now if you're stable now that I'm stable, can we talk about coming off? Because both of these long term are really going to cause problems. I mean, I don't think you can escape metabolic syndrome and all of those, a diabetic state with these two medications, because both of them super high risk. Okay, Ganesh, hello. Man, please start making videos about therapies also. Yeah, I have one on CBT and IPT, I believe. It's an older one of my videos. Again, not that popular, unfortunately. But I do have a video on that. So if you haven't seen that, check that out. It's one of my older videos on cognitive behavior therapy and interpersonal therapy. And I talk a little bit about like psychotherapy, talk therapy in that video. I'm not an expert in therapies, though. I'm a psychiatric nurse practitioner, and I focus more on integrative mental health approaches using holistic, what people would call alternative approaches, diet, lifestyle modifications, to treating mental health disorders, and particularly depression and anxiety. And so, my therapy knowledge is limited to like more of a CBT, because that's what I learned in school and what I studied a little bit after school, but not as much as like say a therapist would understand the therapies, and all of the different, there's hundreds of different therapies out there. So certainly not really my expertise as far as that's concerned. So what I do know about therapy, um, and what I can speak on it, I did mention in that video on CBT and IPT. Okay. Ethan LaBelle, hello. Is PSSD real? Have you seen this in your practice? Thanks. I have not seen it in my practice. Um, it is. I'm guessing it's real. I still have a hard time with this concept, um, just because I haven't seen it, I guess. Um, but what PSSD is post SSRI sexual dysfunction. So meaning people who take an SSRI, they develop this sexual dysfunction, low libido, whatever it may be, because of the SSRI, not because of their depression. And then they come off of it or they switch to something else, and it's still there, and then they stop antidepressants altogether, and they still have this presentation. I haven't seen it. I've talked to other providers who haven't seen it, that work with a lot of patients. So not something that we've seen collectively in my practice, in the psychiatrists I work with, other psychiatrists I've spoken to. However, there is a channel, Dr. Joseph Witt-During has a channel called The Taper Clinic. And I actually had an interview with him that'll be coming out here soon. And he has people on his channel that talk about this and bring it to light. And that's when I first some people were talking about it in my comments with some of the medication. I'm like, I've never seen that. Like, what are you talking about? And then I saw a couple of vague research articles about it that it was still questionable in the research, because there could have been other reasons why these people were having this. But he brings people on to talk about medication reactions. And he's very against medications and works on tapering people off of various different medications, because of all these types of reactions, and particularly psychotropic medications. But he's got several people on his channel that report this and talk about it. But I don't know. If I were to see someone with this presentation, I would be asking a lot of other questions, like what are your hormones? Um, what is your uh, dietary load of glyphosate? Because that can bring testosterone down significantly. Glyphosate is a pesticide that's on foods that if there's not organic, you're eating glyphosate. Um, Now, even if you eat organic, people will say this. They'll say, well, yeah, but it's not, it still may contain glyphosate. Yeah, but it's going to contain a lot less. And the reason why it would contain it is because of runoff from other farms that have glyphosate. Like it's in our soil, unfortunately. So we can't just get away from it 100%. But you can certainly lower your burden of glyphosate by eating organic. And it's worth it, especially if you're having something that you think is PSSD and maybe it's not. Maybe it's vitamin D really low. You need vitamin D to make dopamine. Maybe it's your dopamine being very low because dopamine and testosterone have this um, relationship where if one's low, the other's going to be low, and so we got to look at those cofactors. We got to look at all of those nutrients, and so that's how I would approach it first before saying that that's what it is, because I've had patients who've had um, SSRI induced sexual dysfunction, low libido, um, maybe erectile dysfunction or something like that, and either switch them to another medication, added a medication to their regimen, and it gets better. If and when they come off of their medication, they don't have it again. So I just haven't seen it. And other clinicians say the same. So that's what makes me think, I wonder if there's something else going on, or maybe it's just really rare. And the people who do have it are the ones on Google, on YouTube, trying to find answers. And so they're drawn to channels like his. And so, because he's had a couple on there that talk about it. And so it makes it seem like there's more, than what there really are when it's highlighted like on a channel of the PSSD. So I'm guessing that it is real because I've heard stories of people who have it, but I would wonder why they have it, and I would be questioning the why, the root cause, and looking more in that direction than kind of going along with this PSSD, that's it. You're just stuck with it the rest of your life, because that's what it sounds like. It sounds like these poor there were guys. I haven't seen women. There were a couple of guys. I think two stories that I saw, but I think he might have had a couple more males with it. So it just seems like there might be something more to it. But I would say it's rare. If it is something that is out there, that it's very, very rare. Hi, Noah. Would I feel a difference with higher doses than 2,400 milligrams of gabapentin? I heard something about saturation level. It is possible. Like I said, 3,600 is the max dose. And I already cautioned you about the long-term risk and all of that, having to taper, blah, blah, blah. But just so people know who might just be joining in, that we talked about Maudsley deprescribing guides and gabapentinoids and all of that. Um, so, but yeah, if you're looking at tackling your symptoms this way, it is possible to get more effect. Now, saturation level is what happens with all these different medications that are considered psychotropics and working in the brain. Like I mentioned earlier about neuroadaptation, this can happen with antidepressants. It can happen with the benzos, with gabapentinoids, anything that's messing around with your neurotransmitters can create a state of neuroadaptation where, your receptors can become oversaturated with whatever neurochemical neurotransmitter you're providing it. In this case, the GABA receptors, and then down regulation happens. So your brain starts turning off certain signals and certain pathways for GABA and GABA transports, and allows the medication to do what it's doing. So that's where you develop tolerance. So if you increase more, you may gain a little bit of effect, but yeah, you can end up at the same point that you're at, where then the brain says, oh, but we're getting a little bit more. Okay, let's turn down this receptor and that receptor. And that's why they're so hard to come off of, because when you downregulate GABA, and then now you eventually come off of this medication, or you try to cross taper or something else. Now your glutamate is dominant. GABA keeps glutamate in check. Now we need glutamate to have energy and to think clearly, to be focused, for me to, answer all of these questions. I need glutamate, like glutamate is something we need. It's good for the brain. Too much glutamate, or when glutamate is unchecked and it doesn't have GABA to bring it down or inhibit, because GABA's inhibitory, that can create problems. Glutamate toxicity is very nasty, and is very excitatory. So it can create this presentation of what looks like autonomic instability. It looks like neurotoxicity. Can look like many things for different people. It presents in different ways, but yeah, you can certainly do that. And yes, you can get to higher dose, but once you get to a max dose and you reach the saturation level and you start noticing that you're not getting benefit, that's where they're limited. And that's my thing with benzos, do the same thing. And of course the gabapentinoids and the Z drugs, the zolpidem, the sleep medications. So you just have to be very careful going down this path long term, because of this effect, this neuroadaptation. And then, if you have to come off of it, you make sure you come off slowly. And like I said, make sure you get that book to help prevent glutamate excitability and significant withdrawal symptoms. Okay. Lulu, hi. Hi, Lulu. Thank you so much for the super chat. Haven't forgotten you. Let me see here. Thank you. Thank you for the support. So Lulu says, just for everything you've done for me. Thank you so much. Question. So many conflicting thoughts from the psych community on chemical imbalances, so many on big pharma meds. Thoughts. Yeah. So very, very good question here, and point to bring up is there was a paper that came out just a couple years ago. It's on Mark Horowitz's website. If you just Google Mark Horowitz, he has his papers on there. And this was one of his papers that he did, where he reviewed, it was like a review of the literature on, is there really a serotonin, a chemical imbalance that is driving people who have depression. So when he did the review, I don't know that it was a systematic review, but I know it was some kind of a review of the literature. And the bottom line was no. Does that mean that there is no person who's low in serotonin? No, because there are. You can see that in someone who does an oats test. You can see the metabolites of serotonin and see there are people who are low. What it means is that, statistically speaking, it's not the main cause. So it's not like the cause that they can say this is the cause of depression is serotonin, because depression is multifactorial. It is, and so it's not just a chemical imbalance, or may not be a chemical imbalance at all for someone. It may be a nutrient deficiency. It may be thyroid dysfunction. It may be inflammation. It may be you have MTHFR. It may be you have VDR, receptor gene problems. It may be, you can't utilize your omega-3s. It can be like on and on and on. So there are all of these other factors that depression can be a result of. So I don't think, any study is going to be able to pinpoint exactly what causes depression. But I know for a fact that serotonin can be one of those factors based on many different things, because I've seen it in practice. But in his study and review of the articles that he reviewed, statistically, it was like, no, it's not the cause of depression, because it wasn't enough of a statistical significance. There weren't enough people that were affected to say that it was a root cause, that it was the cause, I guess I should say. But it can be for some, for a small group, for the people that their serotonin was low. What about them? You know what I'm saying? Because there are people in those studies that he looked at that, yeah, their serotonin levels were low, but not enough to make a statistical difference. So it's important when we look at research articles that make these big claims that we look at how they got to that claim. So we're looking beyond just the abstract, the conclusion. We have to look at their methodology, how they came about it. And when it comes to reviews like this, what did the papers actually say? And because to say that serotonin or chemical imbalances don't exist, it would mean zero patients would have that, but that's not true. There are some people who do have low serotonin, low dopamine. I see it all the time in an oats test, in presentation, and in research studies that draw on cerebral spinal fluid. They can see that too. So that would be the way to tell if it's in like your brain specifically. An oats test is looking at the metabolite, so it could be from the brain and the body, because we have serotonin all over in the gut, is a majority of it. But so it's looking at those metabolites of serotonin. So it's looking at overall in the body. But certainly if you have a low level, you're going to have it, it's going to not just be in one area. It's going to be all, throughout. So you can assume that, you can theorize that from an oats test. But the studies that were used, they look specifically at cerebral spinal fluid, which is more sensitive to brain serotonin. And yes, there were samples that did have low serotonin in those studies, just not enough to make a statistical difference. And so the conclusion was serotonin thing is a myth. Okay. But I do have to say that Big Pharma does use that as a jump off point to say, to drive their ads and say everybody has a chemical imbalance, and that's not okay either. So there has to be this fine line of, some people may have this chemical imbalance, but why do they have the chemical imbalance? Is it nutrient factors? Is it inflammation as a factor? Is it, all of these other things that could be causing you to have these problems, that can create these types of imbalances or presentations of symptoms that we call depression and or anxiety. So I think that's more the question there is, again, going back to individual treatment, which is what I focus on. Each person is different. Each person's root cause is going to be different, of why they have depression or anxiety. So definitely not everyone has a chemical imbalance. And those who do, it's very small, those who have a chemical imbalance. But we're not saying that it doesn't exist, because it does. So that's my take on the whole psych community chemical imbalances theory. They've debunked it with the study, but it doesn't mean that it doesn't exist. It's just not the root cause of depression. It's not in the studies, statistically significant. Like a lot of people in the population that are being treated with antidepressants have low serotonin. So that just goes to show that we need to look at depression as multifactorial. There are many factors that are contributing to this presentation of the symptomology. And so it's up to us to look for those root causes. That's ultimately what providers should be doing. But unfortunately, we're not there yet. Eventually, though, we will be there yet, because we're heading there. Educational institutions are starting to catch on to this. It's starting to slowly integrate into our education. And once it starts getting into the education and providers are educated on this, the more providers are going to start. This is going to become the norm eventually. It's just that research and the way that all of this goes takes a very long time before it gets to implementation. We already have the research that shows a lot of this stuff that I'm talking about. It just doesn't come from the sky. It's actually true. There's lots of studies that prove what I'm talking about when I talk about nutrient deficiencies, cofactors, and micronutrients, etc. All these other things that can lead to depression and anxiety. But for it to actually lead to practice changes in the way that we as a whole group move from conventional sick model to preventative root cause medicine, that's going to take many years, but that is the direction we're heading, thankfully. So I just happen to be on the front lines of it, and I'm proud to be on the front lines of it. Thank you, Lulu, for your comment. All right, Zach. Hi. They got me on 5 different meds: alprazolam, Abilify, Catapres, Wellbutrin, and Zoloft. Is that okay? Is that okay? Oh, okay. We got to be careful with Abilify and Wellbutrin. There is a CYP2D6 component there. I just know that from the top of my head because I've had patients on Abilify and buproprion, which you can do. You just got to be careful. The Abilify isn't high because you can have side effects from that because of the Wellbutrin is a strong CYP2D6 inhibitor. So safety-wise, be careful there. I have seen people on more than 8 medications. Is it okay? It can be safe. But when I start seeing this, I start wondering why. Why do we need to keep adding more medication? What is going on? I imagine you must be having, significant anxiety and perhaps depression with this combination, and that's why you're on this combination. And if it's helping you, great. If you're finding you keep hitting a wall, and then they say maybe we should add this or maybe we should increase that before your psychiatrist, talks you into adding something else. Ask about doing labs or see someone to do your labs, because oftentimes when I see someone who needs a lot of different medications to treat their symptoms, and it's a progressive thing, it's because you're missing those nutrients that I've been talking about throughout today. You're missing key nutrients, or there could be something that we're dealing with under the hood, so to speak, that we could see in labs, maybe an autoimmunity condition, maybe inflammatory markers, maybe homocysteine, which would indicate something like MTHFR. I mean, there are many things that we can discover looking at the labs and doing at least the basic labs that I mentioned in the video I do on basic labs for mental health. So make sure to look there. Make sure to do your labs. Ask about these labs. Don't just have them do a CBC, a CMP, and maybe a TSH and tell you you're fine. That is not enough. And a TSH is pointless without a free T3, a free T4 at least. A reverse T3 would be better in there. And then your antibodies to rule out Hashimoto's. Your TPO and your thyroglobulins and those factors. So you need to, when you're getting these labs, ask for them specifically. The ones I mentioned in my video, at least start there. And then, look at what could be deficient or what could be causing some of your symptoms. Because when you keep adding more and more and more, like the one gentleman said about saturation, you're filling holes in a bucket, but the bucket has many holes. And some of those holes are, in fact, and the bigger holes that we have to really fill are the cofactors. So you can plug it up and feel a little bit better by giving a little more serotonin, a little more dopamine, modulating with a little bit of norepinephrine or alpha adrenergic here with clonidine, to get the anxiety. You're just modulating different receptors. But if you're ignoring what's really going on and what's really causing the holes in the bucket to begin with, you will never get a full bucket. And so and so that I think is more important to focus on than the number of medications you're on. And certainly I would not recommend just stopping medications on your own, because that can be very dangerous, especially if you've been on them long term. So it's a conversation to have with your provider, like, hey, instead of adding on medications, can we look at some root causes? Can we look to see what else could be going on before I start adding more and more and more? Because yeah, you can set yourself up for something called treatment resistance. And then they're going to start talking you into other more invasive treatments. So before going down that path, please, please, please do your due diligence and check labs, for mental health and even beyond, depending on your symptoms. Work with someone who understands this. Psychiatry Redefined, the program, I just did a year. I'm doing a second year with him, with Dr. Greenblatt, because the information, there's so much to learn. You cannot do it in a year. But he has providers. So he trains providers in this functional integrative approach, right? And so he lists providers I think it's under resources on his page, psychiatryredefined.org. And he lists providers there. So you can try to find if there's a provider that understands what I'm talking about right now in your area, that can potentially help if you're in the US. I think he has providers from other countries too. So you may be able to find a provider in your country if you're not in the US, if you check his website and look under the resources page. And then you have to control F, your state or whatever, or your area, to kind of find them, because he doesn't have them listed yet in categorical, order to find them easily. Hopefully that'll be something he does later on. But anyway, that's a way if you don't know where to find a provider that does this kind of stuff, that's a good place to start. If your provider just looks at you like you've got two heads and says, what root causes are you talking about? Let's just keep adding. Didn't you hear about the chemical imbalances that you probably have? And they just keep going on and on and on. Definitely that's a red flag there, and look for someone who can do this type of approach. Okay. Paco R, hello. I am off Abilify for 2 weeks now after tapering off, still having difficulty sleeping well. Okay. Could this be a withdrawal symptom, and when will it go away? Um, yes, it can be, depending on how fast you tapered off. Um, you've been off of it 2 weeks now. The antipsychotics usually, for the most part, are fairly easy to come off of, but you still have to come off of them strategically, by the lowest dose, slowly, not real fast. But they're certainly a lot easier than the antidepressants, the benzos, the gabapentinoids, and all these the Z drugs, everything that's listed in that book. But anyway, if maybe you came off too fast, and this is going on 2 weeks, give it another couple weeks to see if it goes away. But then I would also ask you this, Paco, did you have trouble sleeping before you were on Abilify? Because that would be very telling. Was there something going on before they put you on Abilify that was causing you to have problems with sleep? Because then that would be, okay, maybe we're now back to square one. You're off the medication, but we're still dealing with what was the cause of why you couldn't sleep. So that, okay, so you had problems. So that makes more sense to me, because that oftentimes happens. People want to come off medication because of whatever reason. There's lots of reasons, side effects. They don't want to be on them long term. They feel fine now and they want to see how they do without it. But if the root cause hasn't never been addressed of why you were on the medication to begin with, then yes, those symptoms can reemerge. And so the question is it's not that you have an Abilify deficiency. It's something was going on that was making you not sleep. Then the two culprits here, a lot of times with insomnia, if we're talking about nutrients, are magnesium and zinc. because that's what's required for us to convert serotonin to melatonin. You see, people don't know serotonin is a precursor to melatonin. So in order for that conversion to happen properly, we need enough zinc and magnesium. Um, and then of course, for serotonin and everything to process into 5-HTP and not go down the quinolinic pathway, we need all these cofactors, because that's the thing. That's the other thing I forgot to mention with Shelley's response on chemical imbalance. You can have enough serotonin, but if your serotonin is going down quinolinic pathway or kynureninic pathway, um, you're going to have inflammatory markers, inflammation markers. So it doesn't matter if you have enough serotonin because you don't have these the cofactors in order for it to go into the right pathway. You're going down the stressed pathway, which creates toxicity. You can see that in an oats test, quinolinic acid and kynurin. So yes, so basically, with tapering, this could be the presentation in a couple weeks. Give it a couple more weeks just to be sure. But I would more so be looking at understanding that the sleeping difficulties were there beforehand. Why were you having sleep difficulties? Could it be nutrient related? Or could it be, a lot of people develop insomnia based off of habits and things that they do while they're in bed, that you start associating bed with thinking and ruminating, or you start associating bed with I'm on my phone, I'm in dopamine mode, I'm scrolling, right? I'm watching TV. Like all of these things eventually can lead to insomnia because of poor habits, and our body, like our brains can be trained, right? Just like that's how therapy works. It works to retrain the brain because we've trained our brains to do these certain things. And so you could train your brain to have insomnia because you start associating your bed with all of these other things, which are alert signals, right? Scrolling, dopamine, ding, ding, ding. Now you're just alert. When you get into bed, you start associating it with that. Thinking, ruminating. Now you're like, okay, the brain thinks bed is for thinking. So I'm just going to keep thinking. I'm going to be alert and awake so I can think. So CBTI, very good for that. If that's it. If we're thinking nutrient deficiencies, make sure to specifically look magnesium, zinc, but we cannot ignore all the other cofactors, for serotonin specifically when it comes to sleep as well. So the micronutrients to treat depression video could be helpful, and the basic labs for mental health video could be helpful for you to look for and make sure that you're correcting those, because you could probably gain a lot of benefit there to help these types of symptoms here. Great questions. Okay, so we'll take a couple more here because we're over the 2-hour mark. I don't know if he'll tell me how many questions we have. If there's a lot, then I won't be able to do them. But if there's only a couple more, I'll do a couple more. 4 more. Okay, I'm going to do 4 more questions and then we're good. Okay. All right. Then we would have answered all the questions. So unfortunately, no more questions. Come to the next live, August 17th, as long as Raul's available. We will do that on August the 17th. I'll make sure to put out he says he's available, so we're going to do it then. And I'll make sure to put out the notification here in the next week you can put the reminder on. So just mark it on your calendar. And then I'll be doing the newsletter as well, with some articles and answering some questions from previous live streams that we didn't get to answer. But in today's one, we're going to answer all of them. Okay. So Barbara, can you tell me, is benfotiamine good for anxiety? Thanks. Benfotiamine can be, in particular, especially if you have the thiamine, like a deficiency in thiamine, or even if you're subclinical in that, you can do a micronutrient test for it. They'll check your plasma for it. It's a hard test. It's hard to find in the serum a deficiency. But as long as your kidneys are functioning well, as far as, because some people will be afraid of overdoing vitamins like that. It's water soluble, so it can be excreted as long as you have good kidney function. But a lot of times benfotiamine can help anxiety, in particular with that type of presentation. And people who also have gastro symptoms, there's something called gastric beriberi, which beriberi is like if you have significant thiamine deficiency, you'll have this beriberi. Um, but you can actually get a presentation of gastric beriberi with a subclinical thiamine deficiency. And so you get a lot of gastric symptoms. And particular, this is the case for people who are on medications like PPIs, like proton pump inhibitors, and medications like metformin. And if you drink a lot of alcohol, you can create this effect where you can't absorb your B vitamins and B1 particular, right? So, so yes, benfotiamine can be very helpful. Um, it's more available as far as absorption goes, but some people, um, if you're sensitive to certain things, can have reactions, especially if the anxiety is related to like um, an effect of maybe tapering off of medications. That's a little different. You got to be a little careful with how much benfo you use. But yes, answer is yes, but it does matter, like it as far as where your anxiety is coming from. So we always have to go back to root causes. So it can be if you're having certain issues that are related to thiamine in particular. Um, what's his name? Elliot, Eon Nutrition, EON Nutrition has a YouTube channel. His name is Elliot, and he is a benfotiamine thiamine expert. Tons of videos if you want to really go down the rabbit hole there on thiamine. But yeah, lots of uses for it. But you could really learn a lot on his channel about it. Caleb Bolin, hello. $10 super chat. Yay. Let's give us. Thank you so much. I really appreciate that. Thank you for the support, Caleb. Thank you for your response. A friend of mine has borderline personality disorder, and I'm really trying to work with them on it. They take Zoloft and Lamictal. Do you have any advice on how I can get along with them better? Well, you have to set boundaries with patients with borderline personality disorder, because it's in their nature to test boundaries. That's number one. Always make sure that you know that you let them know that I'm here for you, but you have certain boundaries, right? That needs to be respected in order for you to move forward in the relationship. Okay. That's important. So when you're setting the boundaries, being firm with that, and just letting them know that you're doing it out of love for them, because you want them to learn how to respect boundaries as well. That's going to be part of their healing. And it should be, if they're in therapy, part of their therapy. They need to learn boundaries, how to respect other people's boundaries, number one, because that's a huge thing with them, but also how to set their own boundaries as well. So I would say that they can get into a lot of black and white thinking, and a lot of something called splitting, where one, maybe you're the good friend this week and you're the only one that understands them and no one else can. So that might be you're in their favor this week, right? But then you can get to the other side where now there's another friend that they say, no, but Susan's now my best friend, and you're Caleb, you're just bad. You don't understand me. There is no gray. It's hard for them to see the gray. Therapy helps with that too. But when you're dealing with someone like that, and they're puffing you up as you have to remind them, like, yeah, I thank you for, thinking I'm a good friend. I'm going to stand by you. But, there's good qualities in some of your other friends. Like, try to help them see the gray. Try to help them to see that so-and-so is not all bad, because that can help them. They should be learning some techniques on how to do this in therapy. Dialectical behavior therapy is really good for this. So hopefully they're with a therapist who understands dialectical behavior therapy in treating borderline personality disorder. So maybe guide them in that direction as well, but helping them to see the gray, and not everything is black and white, making sure you're setting your boundaries. because they can go off the rails when they're irritable, when they're angry. They can say things they don't mean oftentimes, and then they want to take it back. But you have to make it clear that you have feelings too, and some of the things that they say may hurt your feelings. So open lines of communication is very important there, and just the way that you present, how you speak with them. And then they should also be learning how to speak and communicate their feelings. And there's something within dialectical behavior therapy called it's called the Dear Man. It's an acronym for helping someone who has this problem, communicate their feelings well. And maybe that could be something you could use. If you Google Dear Man, DEARMAN, it'll kind of go through. Maybe there's some handouts online. I know I have handouts that I use with some of my clients that have borderline, and just kind of helping them get through. Like, I'm mainly focusing on their medication management kind of side of things, but I want to give them a resource. I'll send them something like that to help them. But certainly those types of tools, the DBT skills and tools can be useful there for you and for your friend, to understand and to utilize, to keep those communication lines open, to make sure you're setting your boundaries with them and helping them see that things are not black and white. I think those would be the best tips there I can give. But you're a good friend to them, for asking questions to help support them. I can tell you're a good person, and I'm sure that they appreciate it too. So thanks for the question. Jero Houston, hello. Hi, I have low energy without joy, mental fatigue, very worry. I take before fluoxetine and hasn't worked any, and amitriptyline. What do I do? Low energy, mental fatigue, very worried, fluoxetine. And maybe you were on fluoxetine before and now you're on amitriptyline. What do you do? Well, make sure before you switch or whatever, the reason, with your medications, that you're maximizing the dose. Amitriptyline is a tricyclic antidepressant that can be stimulating because it's acting on all, norepinephrine, serotonin, and has downstream effects for dopamine as well. Um, and it can be very powerful in that regard, so to speak. So make sure you're slowly titrating and giving it time to work. I think that's key, to give it time to work. But go back to what I've been saying before. Make sure that you're looking at your root causes for this low fatigue and this mental fatigue, anemias in particular, iron deficiency. Anemia comes to mind, B12, B6, B9 deficiency. Make sure you're looking at homocysteine when you check your Bs. And then omega-3s, make sure you're looking at your omega-3 index and checking your omega-3s, because that could be a cause of mental fatigue or low energy. And if you had a presentation where you were super anxious and then crashed and developed this mental energy, or this mental fatigue and low energy, it could be adrenal fatigue. So that would be, checking your cortisol and doing a salivary cortisol test to really look at what your cortisol awakening response is, and what it looks like throughout the day. That can guide treatment if that's what you're dealing with. But when we're looking at the medications, amitriptyline should, start increasing your energy. And if not, I would start looking at what could be missing, making sure you're ruling out your nutrient deficiencies, etc., and any type of anemic presentations, adrenal fatigue, that kind of thing. And then another reason why medications may not work, that I haven't mentioned today, but have mentioned in other streams, could be genetics. Maybe you're rapidly metabolizing these medications. Maybe you have some kind of metabolic SNP, polymorphism on one of these CYP 450 enzymes that inhibits you from getting any benefit or limits the benefit that you'll get from the medication. So that could be something else that you could look into as well. And that you would do with like a gene site test or like a genome test. I always prefer genome. I just really love that they do a little bit more with the genes, and I love their reports. They're very more detailed, and they're testing a bit more genes than GeneSight does. But both will give you good information. Okay. Next, how much different effect do people who work out and people who take antidepressants have for who had depression and anxiety? How much different effect do people who work out have? So I guess what you're asking is, how much does exercise actually impact the way that antidepressants work? Well, I have a video on this and it's very detailed. It was one of my first videos. Um, and it's called How Exercise Treats Depression. And it gets very sciencey. I understand that. So a lot of people commented on that, but it is, if you can watch it and maybe watch it again to get through the sciencey stuff and understand it, what it's basically saying is that exercise increases BDNF, which is brain-derived neurotrophic factor. It increases circulation to the brain. It also increases dopamine and norepinephrine and serotonin, and increases these different neurotransmitters in the brain. So yes, it can be very, very helpful to treat depression alone. There are studies that show this, and I mentioned that in that video and in the description, the studies. Okay, so you can see that in more detail there, as far as how exercise treats depression and the fact that it can treat depression on its own without medication. So the fact that it can improve BDNF, neuroplasticity, it also reduces inflammation. So it's hitting a lot of these factors. Like I mentioned, depression is multifactorial. So because it's multifactorial, exercise really hits a lot of those factors, right? It's not just serotonin. It's not just chemical. We talked about that. It can be inflammation. It can be, circulation problems. It can be neuroplasticity. Your brain has been trained in this certain way. So anyhow, exercise can be very, very beneficial on its own. Adjuncting with exercise versus adding more medication is definitely a healthier approach and can yield positive benefits. Now, the question is, how depressed are you? And how, like, is your depression causing a lack of motivation to start exercising in the first place? I think that's a question to ask as well, because that would hinder, how much exercise you can do. So if you're in that position, maybe starting off slow. Like, it doesn't have to be rigorous. In the research, I bring it up in the article too, it's really moderate exercise that they've shown. High intensity can help too, but what treated depression in several of the different studies, moderate level depression. So you don't have to go, you know, you know, on the treadmill, or do a high intensity interval training right off the bat. You can start with walking. You can start with yoga, light yoga, and just introduce it slowly if that's where you are right now, until you can start gaining benefit and getting a little bit more of that moderate intensity, and building off of that. But yeah, someone who's exercising and working out more and at least getting that moderate intensity is going to have a way better chances of antidepressants helping them, and a lot more quickly as well, and may not even need antidepressants to begin with. Great question. Okay, Blue Fari. My sister's on Abilify 10 milligrams, Zoloft 100. She's bipolar 1. Take these once in a month, only doing excessive shopping, gambling, impulsive decision, hypersexuality. Take these once a month. Okay. If she's only taking them one time a month, that's not going to be effective to treat her symptoms. It sounds like she has either OCD, like behavior with the bipolar, um, or her bipolar is not being managed. Now, you need to be taking these medications are daily. So I think you need to talk to your sister about, you can't just take them one time a month. It's not gonna work that way. You've got to take them consistently, to help with these issues here. Now, the gambling and impulsivity, um, especially the gambling, I bring that up because that can be a presentation of bipolar 1 in a manic episode. Okay. So this is where Abilify is going to be more important. Zoloft is typically brought in when someone's already stable and they have a bipolar depression, but it's brought in with caution because you can flip someone into mania. So, your sister needs to talk to her psychiatrist about, the fact that she's only taking her medication one time a month. She needs to be taking them daily, and she probably needs to be, just starting off with, if she's in this manic phase, with the Abilify. Now, the one thing with Abilify is there is this side effect, very rare kind of thing that happens, where the person can be more compulsive with the gambling. Not sure why it's really left as an unknown and why this is happening, but that can be a factor with Abilify, so that could be kept in mind. But you know if she takes it, the Abilify, 10 milligrams, a couple doses, you should notice if a lot of this stuff gets better, then it's not the cause. And if she's only taking it one time a month, I doubt it's the cause. And it sounds like this is more of a manic episode. So talk to the psychiatrist, talk to her psychiatrist, or have her talk to her psychiatrist, and make sure that they know she's in a manic episode. She's only taking her medicine one time a month. We really need to step in with an antipsychotic, let the antidepressant alone, because you shouldn't be on that when you're in a manic phase. So that's what I would be discussing with her psychiatrist at this point, because this leads to destruction, in the bipolar person's life, and can really ruin relationships, and then they end up in a couple weeks. Now she's going to be depressed and have to deal with that. So make sure the provider knows what's going on. I think that's key, and that she needs to be taking her medications every day. Okay. Skelly MC, hello. Would it be smart to combine vortioxetine 5 milligrams with Wellbutrin 150 milligram XL to save money, since Wellbutrin increases vortioxetine serum level higher? Yes. Okay, hold on. Yes to Wellbutrin will increase serum levels. Would it be smart to combine vortioxetine 5 with Wellbutrin 150? Is it smart? It's risky. Okay, it's risky. I wouldn't say it's smart. It's risky, but you can. And good thing that you noticed that Wellbutrin is a potent CYP 2D6 inhibitor, and vortioxetine uses that pathway, which is why I said you got to check for drug interactions with vortioxetine and even with Wellbutrin. But anyway, so you could technically do this combination, but you have to be very, very careful. You have to keep vortioxetine levels very low. So I wouldn't even go past 5 milligrams. Maybe 10, but that would be it. Because the max is 20 with vortioxetine. And if I remember reading correctly and up to date, because that's what I use, it's a professional database for looking at drug interaction checks, and it really helps you to see what you can leverage, what you can, and all the different studies involved with it. But I do believe you can go up to 10 milligrams with a combination like this, because I did try it once before a while back with someone, to help leverage, maybe a little bit more of that norepinephrine and dopamine effect, because they're having comorbid ADHD, anxiety, depression, and we were trying to treat it all without overstimulating kind of a scenario. But you do just have to be careful. You have to be careful anytime you're trying to use inhibition of a medication to your advantage, because you just risk this toxicity, and then you also risk now too more sensitivity to like something like serotonin syndrome. So just be aware of that, combining other things that could potentially increase serotonin. But it can be done. It can be done for sure. You just have to do it with caution. Okay. Okay. I think those were all. Those were the 4 questions. Yay. Okay. So we got all the questions answered today. Yay. I did go over, but that's okay. My green tea ECGC was working and I was able to just pump them out today. So thank you all for being here. Next live will be, like I said, August the 17th. Raul says he's going to be available. So it's on. I'll make sure to post that so you guys can set your bell for the reminder and then, put it on your calendar and whatnot. I will also still do a newsletter. So if you're not signed up already, levelheadedmind.com. Down at the bottom, you can sign up for the newsletter, and I'll just answer other questions from previous streams that I didn't answer in that newsletter, along with just some new stuff that's going on and some information there. So the newsletter is very resourceful, I think, for people to get more information, from me and to help further your mental health education. All right. So looking forward to seeing you guys. Thank you all for being here. I really appreciate it. And we'll see you next month. Take care.